welcome everyone. I hope you are able to join us. I am Rachel, Community Manager here at Alloy Women's Health. We are a telehealth company bringing science-backed, evidence-based menopause hormonal solutions direct to your door. I just want to let people know a couple of things. One is that this webinar will be shared on our YouTube channel in another day or two. And today you may enjoy $20 off any purchase on myalloy.com using the code CARE20. And finally, to those of you who have questions for Dr. Morgan, I invite you to type them into the Q&A, and I promise to get to as many of your questions as possible. I am thrilled to welcome Dr. Jayne Morgan back to the Alloy platform. Dr. Morgan is a cardiologist and executive director of health and community education at the Piedmont Healthcare Corporation in Atlanta, the largest healthcare system in Georgia. Within this role, she works to serve health literacy and information both internally to the 35,000 employee system, as well as to external stakeholders. Previously, she served as the system COVID vaccine expert as the executive director of the COVID task force. Dr. Morgan is the recipient of several awards acknowledging her work in providing accurate science and medicine to all communities, including the NAACP Award, the National Women's Empowerment Award, the Atlanta Business Chronicle Award, and the Medical Association of Georgia Humanitarian Award. Dr. Morgan is published in the areas of congenital heart disease, interventional cardiology, and COVID-19. She serves as the health equity advisor of Moderna and is on the steering committees of both Pfizer and Novartis. Previously, Dr. Morgan served as the chief medical officer of the American Chemistry Council, cardiology advisor to the MitraClip team at Abbott Labs, the global director of the cardiology division of Solvay Pharmaceuticals, the assistant professor of medicine at the Cleveland Clinic, and the first African-American president of the Southeast Life Sciences Association, the single largest biotech association in the Southeast. Welcome, Dr. Morgan. It's a pleasure to meet you, to sit with you, and to learn from you today. There's a lot to get into, so I'm just gonna dive us in. My first question is sort of a broad strokes one. I wonder if you could explain the relationship between menopause and heart health. How does menopause affect the cardiovascular system in women?
Rachel, thanks for having me back. And it's a pleasure to be here. And welcome to everybody who's here to really listen about this. It's such an important topic, and we are still learning. We don't know a lot about it, including physicians. And so this is a journey that really began with the Women's Health Initiative. Really, almost 30 years ago, that trial was started. Women's Health Initiative was a large trial, enrolled thousands of women, and really the point of that trial was to look at cardiac outcomes in women who are menopausal or perimenopausal. That trial ended about 20 to 22 years ago. And the results of that trial really changed the trajectory of how we approach women in menopause. Because of the results that were erroneously actually reported in that trial, we actually stopped prescribing hormone therapy for women who were in perimenopause and menopause. Not only did we stop prescribing it, we actually stopped training on it as well. So people like myself who were coming through medical school and coming through training, it stopped sort of cold turkey on a dime. We never heard anything else about it because the Women's Health Initiative results showed that women who are on hormone replacement therapy, estrogen, and progesterone, had an increased risk of breast cancer. Those results completely stopped any further use of hormone therapy. But here we are now in 2023. We started to go back and unwind that and take a look at it. And there were a number of problems. Number one, Many of the people enrolled in that study were as old as in their 70s, well beyond menopause. And so we were using data from people post menopause who were on the other side of menopause by a number of years in their 70s and extrapolating it to this population. Secondly, when we look specifically at the demographic of Black women, many of whom had had hysterectomies, and that is another sort of health equity issue,
Mm,
maternal health issue as to why is it that Black women are subjected to more hysterectomy. So that's perhaps another conversation that we can get into at a later date or with another
mhm,
webinar. But
mhm.
for purposes of this conversation, the women in that section had had hysterectomies. They were Black women, and in those women without uteruses who were given estrogen alone, they had a decreased risk of breast cancer, exactly
Mhm.
the opposite of this therapy. And so, this is how all of this has started to unravel. This is why doctors don't know anything about it, like myself. We're not trained on it. Once it was associated with cancer, everything stopped.
Right.
But here we are taking another look at that and really dissecting that data and saying, what does that really mean? And so when we look at heart disease, one of the things that is very clear is that prior to menopause, during a woman's reproductive life, her risk of heart disease is half that of a man's.
Mm,
Once you transition through menopause, that risk of heart disease equals that of a man. And when you get into your 70s, it actually surpasses that of men. And why
wow.
is that? That is related to our levels of estrogen. Prior to menopause, we have estrogen levels that fluctuate during the menstrual cycles, but generally are much higher and they begin to drop during menopause. And we know that estrogen is cardioprotective, it has a protective factor with the heart, decreases your cholesterol, but also estrogen itself is anti-inflammatory. And we can talk about that, how
Yeah.
cardiology and heart disease is increasingly being recognized as an inflammatory process as well.
Fantastic. Thank you so much. That's a wonderful place to start. Um, I just want to sort of clarify, are there any specific symptoms or signs that women should be aware of during menopause that could be indicative of heart problems or issues? And I'll tell you, I heard from several women on Instagram in my DMs who asked specifically about their heart palpitations, and they
Mhm.
wondered if those are ever an indicator of heart disease.
So the answer is yes and no and no. So let's
Okay.
unwrap this.
Okay, good.
Palpitations in women, often misunderstood, especially if you are perimenopausal. Now, what does perimenopausal mean? You have not entered menopause, but you are in the early phases. Generally starts around the age of 41, certainly can vary all the way up until 50, but that's perimenopause. Still having menstrual cycles. You have not had your last menstrual cycle, but your estrogen levels are beginning to fluctuate. Women during that time can develop palpitations. So these are confusing symptoms. So palpitations are rapid heartbeat or rapid flutter that can leave you breathless. You feel it in your chest. Now, those can send you either to the emergency room or to your physician to check these things out. And of course, you likely have gone through a cardiac workup, which actually is appropriate, right? So if you have palpitations, let's have a cardiac workup. Let's get an EKG. Maybe we need to have an event monitor on you, and then other tests directed based on those kinds of things. But in the end, if nothing is found, we have to begin to consider that palpitations are also a symptom of fluctuating levels of estrogen and perimenopause, and whether it's time to begin to consider menopausal hormone therapy as well. Now, that's not something that is generally ascribed. If you go to a cardiologist, and I am a cardiologist, and you've been referred for palpitations, we're going to work you up for palpitations and look for a cardiac reason for that, either yes or no. If we find something, then we'll do something about it. If we find nothing, you're sent back out into the community. And we need to begin to understand that palpitations are not equal in all sexes and in all age groups. So, yes, palpitations can be a sign of heart disease. They also can be a sign of menopause, and that it may be time to consider hormone replacement therapy.
Thank you, Dr. Morgan. And I really appreciate your saying that, given the physician you go to, in this case, a cardiologist, each one of those specialists, they're looking for an answer to the question that sort of speaks to them directly. And having these conversations is something that's so helpful sort of overall, because it allows women to become armed with the information that can help sort of help them have a more successful appointment. You know, a cardiologist who might say it's time for MHT is a broad thinking cardiologist who understands the role of estrogen in particular. So thank you.
Right.
You're educating us and you're educating other physicians.
That's right. And let's be clear. Most cardiologists are not going to talk with you about MHT
Right.
because we don't know anything about it. We haven't been
Mm-hmm.
trained on it. And so you need to find someone right now, menopause specialists, people who are certified in menopause. Generally, you still see them in the specialty of OBGYN, but I am advocating, because of so much cardiac symptoms and because of the increased risk of heart disease during this transition in a woman's life, that cardiologists also need to start to be trained in it and be very specific to women's health, such that we can be uh, compassionate, empathetic, but also knowledgeable. And it doesn't mean that you should not have a cardiac workup. I want to be clear about that. If you're having cardiac symptoms, we don't necessarily just want to throw hormones at you, but we
Right.
also want to be aware of the entire scope of the person who is in front of us. And as a woman, maybe you should not be treated as a man. There are going to be sex
Yep.
differences. And after your cardiac workup is done and it is negative, then there's another step that we need to
Right.
consider in the treatment paradigm, just as we do in any other algorithm through which we work for any patient, as we get to ruling things in, ruling things out. What's the next step that we go to? Menopausal hormone therapy has to be something that is considered as a part of that cardiac workup, especially if the cardiac workup is negative and that person is in the right age range.
Fantastic. That is sort of pivoting me to a question I wanted to ask later, but is so appropriate right now. Could you speak a bit more about cardiovascular screening of women approaching or going through menopause? And someone asked um, specifically about tests or assessments recommended that women should request as they're approaching or going through menopause. So, for example, coronary artery calcium scores.
Hmm?
What are they? Are they useful? Who should get them?
So there was a lot to unravel there. There's a lot to
Okay,
unpack.
as much as you
Let's
like.
start. Let's have this conversation. Let's
Let's do
start
it.
with a woman's reproductive years.
Okay.
So during the time when you are having pregnancies, if during your pregnancy you have been diagnosed with any of these terms I'm about to use, if any of these
Okay.
terms sound familiar to you, preeclampsia, eclampsia, pregnancy-induced hypertension, high blood pressure, gestational diabetes, or even an older term, toxemia. If any of those terms have ever been applied to your pregnancy, the cure for these risks that can be quite severe, especially preeclampsia and eclampsia, is to deliver the baby safely.
Hmm.
So that's how we've been trained. Once you deliver the baby, then these symptoms resolve. Mother is safe, baby is safe, everything is fine. Hooray, let's clap. We've got a great save. So the treatment for any of these conditions is to actually have the baby. And once the baby
Mm,
is born, the condition resolves. What we now know is that if you have been diagnosed with any of those conditions, then you have declared yourself as having an increased risk of heart disease over your lifetime. In fact, a twofold increased risk of heart disease. In fact, here's how an OBGYN would characterize you as a patient versus how a cardiologist would characterize you as a patient. An OBGYN would say, I have a pregnant patient who has preeclampsia. If you were diagnosed with preeclampsia, eclampsia, gestational diabetes, hypertension, toxemia, then in fact, your pregnancy is actually your very first stress test because it's such a volume overload on the body. And if
interesting.
you receive any of these diagnoses, then in fact, you have just failed your first stress test.
Wow.
And like any patient who fails a stress test, they are referred to a cardiologist. So an OBGYN would characterize this patient as a pregnant patient with preeclampsia. A cardiologist would view that patient as a volume overloaded patient with a failed stress test.
Wow, that's so
And
fascinating.
that's how we need to look at it.
Hmm.
Because what happens after that baby is born and we're applauding ourselves, great save, mom and baby go home, we never do anything about it, there should be a handoff from the OBGYN to the cardiologist,
Right.
just as any other patient who fails a stress test. That patient should be sent to the cardiologist for a workup and then lifelong preventive and maintenance care because she's already declared herself as having an increased risk of heart disease. Now, that doesn't happens rarely, and it certainly almost never happens in populations of color. Back to
Mhm.
maternal morbidity and mortality, increased hysterectomies, not getting referrals for to cardiologists, and more likely to have these diagnoses, more likely to have preeclampsia, eclampsia, diabetes, toxemia, hypertension. And interestingly, all of the risk factors for preeclampsia are also the same risk factors for heart disease. Same risk factors. So if you got those risk factors, you already are at an increased risk of heart disease. Those are the same risk factors that we see in preeclampsia. We've got to begin to make those connections because what happens then these women go on through their life and hit perimenopause. Estrogen levels are starting to drop. Estrogen is cardioprotective. Heart disease is an inflammatory process. Estrogen is anti-inflammatory. They already have a twofold increased risk of heart disease. Now we're going to menopause. Nobody's going to talk about hormone therapy. You see where this is going,
Yes, yes, yes.
right?
Absolutely. Absolutely. Thank you for that.
Mhm,
A couple of things I want to revisit. You mentioned cholesterol
mhm,
earlier. You're speaking about the protective qualities of estrogen. Someone asked about her cholesterol,
mhm.
heart, and hormones. Could you expand on that and also speak to those properties just a bit more that estrogen contains and how it plays a role in heart health? So you mentioned anti-inflammatory properties, for example. Could you just dig in a little more on that?
So estrogen and cholesterol are intertwined in this sort of dance, and we are still working to unravel that. So this brings up a great point, and I'm going to get back to what you're saying. We've got to have research that is specific
Mm,
to vulnerable populations, and women at midlife are an underrepresented vulnerable population. The way that we practice medicine here in the United States, we do these big trials, these companies do these big trials, right? Mostly white men are enrolled and recruited into these trials. We gather all of this great data. There's all of this FDA regulation. The data goes before the FDA. It is approved. We get this new compound, this new drug, and then we extrapolate it to all of the rest of the populations. That
Mm-hmm.
includes women, that includes children, that includes minorities. And here's the thing, most of the world is not comprised of white men. And
Right.
yet most of our drugs are developed for them and by them and extrapolated to the rest of us. If we are included also, we're not included in these trials. And then we also don't have trials that are specific to our
Yeah.
interest, which is what we're doing this webinar. So there are no clinical trials doing head-to-head comparisons of statin therapy versus menopausal hormone therapy in the
Mm.
perimenopausal woman, in the menopausal woman. So here's what we know. So one, I want you to think about clinical trials and remember that clinical trials are the cornerstone of health. And this is how not only do we get information about ourselves, this is how populations who are underinsured or uninsured can actually access health care. Because
Hmm.
by and large, during the term that you are enrolled in this trial, your health is covered and you are
Yeah.
within a very cosseted um, organization where you have a physician who's overseeing that trial, a principal investigator. There's a research coordinator with whom you have direct contact information. If you have any side effects, or as we call them, adverse events in clinical trials, you can contact someone immediately within this closed environment where things can be acted upon. Wouldn't you rather? I've heard people say, I don't want to be in clinical trials because I don't want to have side effects. Wouldn't you rather have side effects while you're in a clinical trial and you have access to a team of people around you 24 hours a day? I don't even have that
Who
access.
are intensely monitoring you?
Who are
You're.
monitoring you and
Mm-hmm.
who are committed to the outcome of this trial,
Right.
as opposed to having side effects after this drug has been approved and you weren't included in this trial and people like you were not included in this trial, and now you're having side effects and you're at Disney World or you're out on
Right.
the side field, right?
Right.
So that's very, very different. And so I want to preface that because we don't have information on head-to-head comparisons between estrogen and cholesterol. Here's what we know, however. Cholesterol is the building block of estrogen, right? The foundation of estrogen is cholesterol. When we look at perimenopausal women, so these are women by and large in their 40s, have not entered menopause, but are entering these early stages where your estrogen levels are beginning to fluctuate, beginning to decline. We also see an increase in cholesterol levels at that time. And so often, what we may do, and that's another story. So I'm going to say what we may do is you may be prescribed a statin. Now, we
Mm-hmm.
have data to show that women are less often offered statins than men, and that women are less likely to take them than men as well. So another question of how women are treated. And when we say women are less likely to take them out, whenever I read this data, I always think that to me sounds as if not enough information was given. That woman is not
Right.
comfortable with the interaction that she's having with her physician.
Mm-hmm.
So as your cholesterol levels are increasing during this perimenopausal and menopausal state, the question is, instead of being treated with statins, should you be treated with hormones to continue to re-regulate bioidentical hormones to bring your cholesterol back into a normal range, as opposed to allowing your estrogen to continue to drop and giving you statins instead? Now, there's some, data that says during that perimenopausal time, if you give estrogen or hormone therapy, depending on whether it's estrogen, progesterone, instead of statins, you actually decrease your cardiovascular risk more so than just giving statins. But these are early studies, not big trials. We've got to begin to look at that. Now, that's the perimenopausal stage. When you're in menopause, when you've actually had your last menstrual cycle and have not had another menstrual cycle since then, your estrogen levels now are at their lowest. And so your cholesterol levels began to rise. That is certainly a time, it seems, to take statin therapy. Still controversial because a lot of the data that was done on statins, we're going back to what I said on clinical trials, was
Right.
done on men. It
Yes.
wasn't done
Yes.
on
Yes.
women. So it's
Mm-hmm.
unclear whether women
Mm-hmm.
actually have this cardiovascular benefit of lowering their cholesterol in menopause the same as men. And those
Okay.
trials need to be done. So that's a long and complicated answer to say we've got to all begin to think about this. And we also need to understand what is the root cause analysis. The root cause analysis is there's not enough data. Why is there not enough data? Because we are not being involved in clinical trials. That also means that women need to be principal investigators. Female physicians need to be the principal investigators, the physicians who are leading these trials, such that we can approach our patients and have them enroll. We know that the number one reason that a patient enrolls in a trial of any race, of any gender, of any culture is if they are approached by a trusted physician. So clinical trials and research are really the cornerstones of why we're having this conversation in the first place.
Fantastic. Thank you. You just sort of wrapped up my next question without my asking it. So forgive the delay. Can you get back to just a bit more about the anti-inflammatory effects that estrogen has on blood vessels, which is not something I was aware of. I bring up anti-inflammatory in particular because it's one of these terms that we hear about a lot, and I don't know that everyone always knows what it means. So if you could kind of home in for us and help us understand just a bit more um, about why ultimately, as much as we do know um, the role that estrogen plays in heart health, just sort of blow that up a little bit more for us as far as anti-inflammatory effects, blood vessel elasticity. I don't know if I'm getting too in the weeds, but these things seem like just things to kind of have in our back pocket to understand a little better.
I love this conversation. So
Oh,
yeah,
good.
talk about inflammation. We are
Right.
not down in the weeds, and certainly, put your questions in the chat if you have some questions. So
Mm-hmm.
inflammation. We have acute inflammation and chronic inflammation. So acute inflammation, we're all aware of, is when you injure yourself, you bruise yourself, and our body reacts to address the injury and to promote the healing process, right?
Mm-hmm.
That's also an inflammatory process that is helpful to us. It's
Mm-hmm.
responding to an injury. The problem is chronic inflammation, where our body recognizes that we are injured and responds, but we're not actually injured. And so it responds with this chronic inflammatory process. Now, what are some of the things where we've seen inflammation?
Mm-hmm.
We know that chronic inflammation is associated with increased rates of cancer. We know that chronic inflammation is associated with increased risk of autoimmune disease.
Yeah.
We see it in first responders from 9/11 as well, and the increased rates of things that they have had. I've actually talked about the 9/11 responders and the chronic particulate matter to which they were exposed. Particulate matter, things floating in the air. We are all Homo
Mm.
sapiens. We breathe in air. So the particulate matter is related to inflammation. So our air quality. And then we also now are beginning to understand that inflammation causes an increased risk in heart disease. So, what is inflammation? So, chronic inflammation in your body can be caused by a number of things, stressors, external factors, but also internal factors. So, for instance, the types of food that you're putting into your body. In fact, there was a study, if you are eating a diet that is high in processed foods, deli meats and hot dogs and fried foods, especially deep fried foods, potato chips, donuts. Am I making anybody's mouth water? All of
You
these
are, and I'm thinking about things in boxes and bags, things, as you
boxes
said,
and
deep
bags,
fried.
artificial sweeteners, artificial
Mm-hmm.
color, all of these are considered pro-inflammatory. So they cause a chronic inflammatory process in the body, but the body doesn't recognize these as endogenous to our system, things that should be there.
Right.
And so
Right.
we work to remove them and heal them. That's a chronic inflammatory process. Turns
Hmm.
out obesity is also a chronic inflammatory process. So the heavier you are, the higher this chronic inflammatory, the higher this inflammation. So for heart disease, and I'm a cardiologist, what we've seen is chronic inflammation can cause a proliferation of the plaques in your arteries. So plaques can build up in the arteries that are bringing blood and oxygen to your heart. And those plaques can be caused by high cholesterol levels or high blood pressure that's gone untreated, accelerated aging. But they then add to those plaques. And as those plaques get larger, they can occlude the artery, meaning they're so big that they block the artery. You don't
Hmm.
get blood supply. That's what causes a heart attack. Or they can loosen the plaque and it can dislodge and move upstream and cause a stroke. So
Wow.
that's how inflammation impacts the arteries in our body. Smoking, cigarette smoking causes chronic inflammation in the body. And so we want to start to reduce that. We know for the first time, people born in the 90s have a lower life expectancy than those born in the 80s.
Oh dear.
People born in the 2000s have a lower life expectancy than those born in the 90s. We see cancer rates decreasing across the board in the United States in every demographic except the younger demographic below the age of 35. Cancer rates are increasing. Over the last
Hmm.
20 years, not only have we seen those cancer rates increasing, we've seen the obesity increasing in those same 20 years. So we're beginning to recognize obesity as a toxicity based on the duration of time that the body remains in an obese state. So, in other words, previous generations would become overweight, but generally later in life,
Right.
in
Right.
their 50s, in their 60s, your fifth and sixth and seventh decade of life. Now we see people who are 30 and 40 who spent their entire lives in an overweight state. That's called the toxicity of obesity. And it seems to be related to the duration of time that the body remains in that
Hmm.
state. And so we're starting to get a lot of information about that. Now let's get back to menopause. When we look
Hmm.
at data, women who've had a life or at least many years of eating a diet that is pro-inflammatory. So lots of fried foods, lots of processed things, lots of packaged foods, artificial sweeteners, et cetera, donuts and cakes. And it doesn't mean we can't eat these, but I'm saying your diet has predominantly been this.
Sure.
And we see that they enter menopause a year and a half earlier
Wow.
than women who have not had those diets. So we
Wow.
know when we talk about food being medicine, it's something that you've got to start over your lifetime because it's going to impact when you enter menopause. Menopause is going to impact when your estrogen levels decrease. Estrogen levels dropping are going to increase when your rate of heart disease will begin to equal that of a man. All of it
Right.
starts with food.
That's amazing. I want to get back to food in a few minutes. I want to
Mhm.
touch on food. I want to touch on exercise, and I'm going to get to people's questions. I It sounds so funny to have gone through 35 minutes of a conversation and have not mentioned hot flashes. And I was thinking
Okay.
about personally, and I know, and so many right here in this community, so many in the world, um, are living with hot flashes. I didn't realize until actually I spoke to your good friend and colleague, Dr. Malone, our medical director here at Alloy.
Yeah.
I didn't realize the connection between the frequency and severity of hot flashes and being teed up to develop heart disease. My
Mhm.
father died from heart disease and did all of the things that you're suggesting
Right.
are not the things to do, certainly on his plate. But it wasn't until I learned that very important piece that I then decided I'm done with this, because I was really sort of muscling through the hot flash thing, but
Mhm.
they were horribly, unreasonably frequent and increasingly severe. And it wasn't until that connection was made for me that I said, I'm done. It's time for MHT. Can you speak to that very important piece?
Rachel, I'm so glad you brought that up. Let's talk about symptoms. This is awesome. So, symptoms, common symptoms of menopause, right? Insomnia, the night sweats, the hot flushes, brain fog,
Mm,
fatigue. Did you know that insomnia or sleeplessness has a direct correlation to heart disease? This is
no,
independent of menopause.
that's incredible.
So it's not only your sleep, it's the duration of sleep, similar to the duration of obesity, the duration of sleep that you have, and the quality of that sleep. And we know during menopause, sleep is frequently interrupted.
Yes,
People can often have difficulty getting asleep, and once you're asleep, difficulty staying asleep. Independent of menopause, decreased duration of sleep is correlated with an increased risk of heart disease. So now we have women whose estrogen levels are dropping, their risk of heart disease is increasing, and they've got an independent risk factor also as one of the symptoms of menopause going on. What is another one that we talk about with menopause and perimenopause, and that's these hot flashes that you brought up.
hmm
We know a couple of things. The severity and intensity of hot flashes is also correlated with heart disease. We know that Black women tend to have hot flashes of longer duration, greater intensity, and over longer periods of time. So, a further increase in heart disease. And so, for us to have this sort of lexicon of let's just suffer through it
right.
begins to be something that's almost intolerable for me as a cardiologist, because I'm recognizing that the symptoms of menopause are also independent risk factors for heart
Right.
disease, and so need to be addressed and need to be taken care of. So absolutely, they're not innocuous. And even, let me just say this, even if they were not um, uh, even if they were not related to heart disease, they are so incredibly uncomfortable, uh,
Yes.
a negative impact on the quality of life,
Yeah.
misery. Our society has a very high tolerance for
Yeah.
suffering of women,
Yeah.
right? Maybe I should go further to say, it's expected that women suffer.
I
We
I
even
I couldn't agree
love
more.
ourselves. We
hmm
grind and we grit through it, including at work, and we are suffering and we are miserable. So, even without a risk factor of heart disease, there's nothing wrong with just feeling better,
hmm
feeling yourself, being able to present your best self to the world, being able to be productive, being able to get a good night's sleep and feel rested. There's nothing wrong with that, even if it didn't have anything to do with heart disease. And that's why it's important to see a physician who's a menopause specialist who can talk with you and understands the importance and value of you having a fulfilled life. There's
Right.
nothing
Yeah.
wrong with that. Right.
Yeah. Thank you for. I'm envisioning this tree, and you're addressing all of the branches on it, and each tree is an individual woman, and there's the piece about the suffering, which is completely unreasonable. There's the piece about your overall health. Certainly, here we're speaking about heart health. Um, there's the piece about the correlation of the symptoms to the potential derailing of your health in various ways. And then there's this sort of like cloak of estrogen that you keep weaving through, which I so appreciate. And the part that MHT addresses, which is all of it.
Right.
To that end, though, I do want to give you. Sorry, my eyes keep watering. I do want to give you time to speak to nutritional considerations, which you touched on, sort of like the what we should eat a lot less of,
Mhm.
and then the impact of exercise and physical activity, and then I'm going to turn to our community questions.
Okay. We're out of town so fast. So here's what I'm going to just add to that. I want
Mm,
people to remember as well as a
mm-hmm,
cardiologist that a woman's symptoms, in addition to all of these risk factors that are not being addressed throughout our whole life, from
mm-hmm.
pregnancy through menopause, a woman's symptoms of heart disease can be different from those of a man. And when we're running after
Thank you.
kids,
Yeah.
running after nieces and nephews, we easily attribute our symptoms to other things. And guess what? Your doctor may as well. Again, this high tolerance for the suffering of women. Women are more likely to be diagnosed with depression and anxiety during perimenopause and menopause than any other time of their life.
Right.
Maybe we should just address what's happening with factual information and
Right.
not about antidepressants and anxiolytics. So something to think about that I take issue with in medical school and in our residency and my cardiology fellowship, we learn that a woman's symptoms of heart disease are atypical. Think about that word, atypical, what that does already in your
Sure.
mind. As a
Sure.
physician, as a person, that means you are some deviation from normal something additional that we have to
Mm,
learn. It's not the main thing. It's something over here that is an aberration. This word
mm,
atypical. And honestly, our symptoms can be much more subtle. You might have jaw pain, right? That might send you to the dentist. You might have back pain. You can explain that away in a number of things. You may feel tired. You may even have flu-like symptoms or a chronic cold that you can't seem to
hmm,
shake. These kinds of things. And you see your physician, and your physician kind of gives you the there, back pat on the
mhm.
back. Everything will be fine. You need to rest. Why don't you take a vacation? When in fact, you're actually having a heart attack. And in fact, a woman's first heart attack is more often fatal than a man's first heart attack. And the reason for that is by the time a woman presents to the medical establishment, her heart attack has been going on for so long as she has been ignoring these symptoms and attributing them to something else. But guess what? The medical establishment has as well, as
So,
opposed to
Doctor,
a man who may have these symptoms, that we see on television and that are
yeah.
true, crushing chest pain, you start to sweat, you're short of breath, you collapse on the floor, everybody starts 911, they get the defibrillator, everybody starts CPR, they call 911, right? You rush off to the hospital, head to the cath lab or whatever we're going to do. A woman's symptoms may not be that way. And then we apply this term atypical to it, which
Right.
begins to denote it to a further lower category. And so we've got to begin to think about that because the fact of the matter is women are the larger part of the population. Maybe it's the men
Right.
who are having the atypical symptom.
Right. Right.
And we need
Right.
to
Thank
actually
you
rename
so
this
much.
and reclaim this. We're the
Yeah.
majority of the population. So I want
Yeah.
to just make certain that people understand while we're having this conversation about heart disease and menopause, and that your risk of heart disease increases during menopause. Your symptoms may also not be triggering and signaling to you that they are heart symptoms because of the infrastructure and society in which we live, the language that we use, and the way that we have learned that a heart attack presents.
And correct me if I'm wrong. I'm so glad you brought this up. Thank you. Correct me if I'm wrong, but it sounds like ultimately it's sort of a slower burn for a woman. So if she's having jaw pain, as you said, she may go to the dentist, back pain, she's feeling tired, she has a cold that won't let up. It is not, as you pointed out, that dramatic, acute left arm pain, crushing chest pain. So
And it
there
can
is,
be. I'm not saying that it won't, but I'm saying then
sure,
we also have this constellation.
right. Right. Thank you. Thank you so much for that. So just
Right.
on nutrition and physical
All right.
activity.
Nutrition and
Mhm.
physical activity. So let's talk about inflammation. So I am admittedly, and you all can come with me on this journey, learning more and more and more about the anti-inflammatory diet. I have a lot of interest in it. I'm reading a lot about it. And one of the things that that I'm learning about it, because we want our bodies to be in the best shape as possible, and food truly is medicine, that we've got to be able to take care of ourselves and take care of our bodies. And diets, just very high level anti-inflammatory diets, you can think a little bit of sort of the Mediterranean diet that
Right.
is high in grains and green leafy vegetables, and a colorful palette. But the other thing that we need during menopause is protein, because we start to lose lean body mass. And we've got
Mm.
to begin to make certain that we're introducing lean protein into our diet. For instance, fatty fish, chicken, turkey. But if you're vegetarian, then think about it in terms of beans. You've got to keep protein in your diet, in addition to these green leafy vegetables. And the other thing to think about is when you're having processed foods, it gives you like these big spikes of insulin as
Right.
well. That also drives that inflammatory process. So begin to think about what that looks like, and how you may begin to incorporate that. Now, all vegetables are not equal. And again, I'm just learning about this. So if you find something that's different, feel free to DM me. But
Mhm.
there are vegetables called nightshade vegetables, and they are called nightshade vegetables because they do most of their growing during the night. These nightshade vegetables, differently from all the rest, have some pro-inflammatory properties. And so
Mm.
people who are following a strict anti-inflammation diet generally avoid nightshade vegetables. Now, I'm going to give you the examples of nightshade vegetables that are totally yummy and we eat a
Mhm.
lot and that we've learned are
Mhm.
very healthy. And they are healthy, but they've got some pro-inflammatory factors to them. And so you just have to balance that. So tomatoes, pro-inflammatory, but tomatoes are high in other essential vitamins and
Right.
essential that we need. So just keep that in mind. Eggplant, mushrooms, some peppers. These are nightshade vegetables that people who are very strict about their anti-inflammatory diet don't incorporate into their diet. Now I'm struggling a little bit. I like eggplant and I like tomatoes, and they've got a lot of positive
A
properties.
lot of benefits,
So
sure.
you need to start to think about that. And as I mature in my journey, I may finally come down on one side or the other about tomatoes.
Sure.
So you may
Sure.
hear me talk in 6 months, and I've finally made a decision about tomatoes. But
Right.
right now,
Right.
I haven't made a decision. I'm just going to tell you that they are considered pro-inflammatory, and
Mm.
that people avoid them if they're following an anti-inflammatory diet. However, because they are nightshade vegetables, however, they do have a lot of other positive benefits. And the other thing to think about in inflammatory diet, this is all testimony. And in medicine, we do not move towards testimony. We like to see randomized clinical trials. So
Sure.
testimonies of people is that once they cut out tomatoes and these nightshade vegetables, their joints and things feel better.
Yeah.
So
Yeah.
sometimes a lot of these aches and pains and things that we're having, I didn't talk about that, as we get older, have to do with our hormone fluctuations. And again,
Sure.
talking with your doctor about menopausal hormone therapy for your aches and pains may have a better outcome than taking aspirin or taking Tylenol or whatever is going to be prescribed. So here's where Dr. Jayne Morgan is on November 9th in her anti-inflammatory
Okay.
food journey.
Lock this moment, people. Dr. Morgan, I wanna pause you on the exercise question and get to some of the attendee questions.
Okay.
I'm
And
just
I do
scrolling
want
through
to
some
say
of them.
one thing about
Yeah.
exercise. I'm a Pilates
Yeah.
instructor. If
I
anybody ever
know.
on Instagram, Pilates with Dr. Jayne, I'm a Pilates instructor. So one thing that we need is we lose lean body mass. We need to increase the amount of protein in our diet, but we also need to do resistance exercising. And
Right.
resistant exercising is incredibly important to keep our muscle mass. So that's all I'm going to say about that.
No, I
Okay.
appreciate that. Thank you. Thank you
And
so much.
Pilates is just one of the things. I happen
Right.
to teach it, so I'm a proponent of it, but there's lots of resistant exercises to do, and it's really important as we get older to maintain flexibility and to maintain lean body mass
And heart health.
and heart health.
Okay. Here's our first question. Can perimenopause cause tachycardia? And forgive me if I'm not pronouncing medical
Mhm.
terminology perfectly.
So tachycardia is another word sometimes for those palpitations. And so the answer
Okay.
is yes. I don't know if you were on
Hmm.
earlier, so I'm just going to do a really brief recap. If you're having palpitations or this tachycardia, make sure you see your physician, get an appropriate medical workup. But if nothing is found, begin to talk with your doctor if you're in the age range of perimenopause about whether or not hormone replacement therapy is right for you for these symptoms.
Thank you. The next question, she writes, post-menopause, had a Takotsubo. I don't know. I'm not sure if I'm pronouncing that right. Takotsubo in August. Pharmacist keeps asking if I'm going to stop my estrogen patches because of this. I'm feeling like I don't know the word, and so I'm screwing up her question.
Mhm.
It's kind of scaring me now to be on the patch, but I feel I need to address my night sweats. Um, no.
So, yeah, I probably can't answer that question. I'm not sure exactly what's being asked and what
Okay,
I
I apologize. I apologize for
that's
that.
okay. I don't know if you mean
How
Takayasus, but anyway, since we don't know, let's not answer that
Yeah,
question.
let's not touch it. Okay, how can we approach our cardiologist about effects of menopause for our newly arisen cardiac issues? We don't want to be dismissed by them by being told that it's part of getting older. I love this question because as you've also sort of woven through um, how ultimately how to be armed when we walk
Right,
into a doctor's office.
right,
So what might you advise to patients who are saying, I never had this before. I never had heart palpitations before.
right.
I don't want to be told it's part of getting older. I don't accept that.
Yeah. Um, that is a tricky question, but we deal with it every day. So let me give you
Hmm.
my answer.
Hmm.
I have to find another physician. And
Mm,
not because this physician is a bad person, but because they're not trained on it. And specifically, cardiologists still are in the journey of connecting cardiology to menopause. Cardiologists are not accustomed to having a discussion about menopause with a
right,
woman.
right,
That's something that the GYNs do, that your gynecologist. And so there's this whole retraining. So I'm not saying be patient, but I'm also saying understand kind of where we are in the whole paradigm. We're out there on the front edge. And quite frankly, with regard to menopause, most cardiologists don't know what they're doing, right? We're
right,
working on cardiology. We are prescribing medications that have been approved on men, and we're extrapolating them to women. That's how we practice medicine all over the world. So after you've had your cardiology workup, if your cardiologist is not receptive to hormone therapy considerations, you need to have a conversation with either your primary care physician or your gynecologist, who hopefully is menopause certified. If they are not, and also have not taken the time to educate themselves, find someone who's menopause certified and take your medical history to them and see what they would recommend.
thank you.
I can't
Um,
emphasize enough, if you're having heart problems, don't just jump to hormones. Please see the cardiologist and
yeah,
get ruled out for a heart problem.
right,
We do still have heart problems. It might be a heart
right,
problem.
right.
So
It does
get
indeed
ruled out
exist.
first. Right.
Great,
And then
thank you.
after everything is negative, then you go to the next step of trying to find that out. Right.
Dr. Morgan, on that, someone asks what cardiac tests and screenings, we spoke about this a bit, but she's specifically asking for women in their 60s who are postmenopausal.
Mhm. So it depends on whether or not you're having symptoms or not. We don't necessarily recommend you having stress tests and echoes and all of these things if you're not having symptoms. Now, that may not be the right way to practice medicine. We practice medicine as intervention. We don't really do a lot of prevention. If you've not had a calcium score, that may be something to consider. But since you're in your 60s, talk with your doctor about it as well. And a calcium score is something that is done just once in your lifetime to give you an idea of your lifetime risk of heart disease. And it can be a guide as to how aggressive you should be with mitigating any risk factors in your life.
Thank you. Dr. Morgan, also, I just want to pause and let everyone know that Dr. Morgan has let us know she can give us an extra 15 minutes. And if you can stay with us, that would be great. I am going to continue to try and get to as many questions as I can. I want to revisit the question by a woman who has defined Takotsubo for us. Forgive me, I'm not perhaps pronouncing it correctly. She says it's a cardiomyopathy of the left ventricle.
Mhm.
She said, I guess the old term is broken heart syndrome. So now I need to find her original question, but she's asking about estrogen patches and having had this diagnosis in August. She's being encouraged to stop taking the patch, but it's really addressing her night sweats. Anything to
Does
add to
she
that?
say how old she is?
She does not, and she's probably listening. So if she gets to answer that question, that would be great. Is there a different 54? There she is.
So I would say that that's something, again, you need to seek out a menopause specialist and
Mhm.
have these conversations. I can't emphasize enough that hormone replacement therapy or menopausal hormone therapy may not be right for everyone, but the conversation is right for everyone.
Mm,
Have the conversation and make a determination, and it may be a discussion that your menopause specialist and your cardiologist need to have and come up with a treatment plan for you.
thank you. How can I know if my high cholesterol is due to menopause or by loss of estrogen? Mine started rising while under major stress and during perimenopause. Years
Mhm,
later, I was finally put on 20 milligrams of statin and my numbers went down. Then I
mhm,
started a whole foods diet and walking, and my numbers went down even more.
mhm,
Also, can I ever go off of the statin?
mhm. So, multi-layered question. One, as you are going through menopause, your cholesterol levels do tend to increase. If they were already high, they're not going to get better. It's just like blood pressure.
Okay,
If,
good to
as
know.
the other thing that we know during menopause, that blood pressure rises, insomnia, that sleeplessness also can contribute to blood pressure. Blood pressure is a risk factor for heart disease. So you don't say this person whether they're overweight or not, but they've been walking, losing some weight. So all of these things are factors. So while you're going through perimenopause, your cholesterol levels were increasing. That was probably likely due to your estrogen levels dropping, cholesterol levels increasing. Now you're on the other side of menopause. You've been taking statin therapy. Your cholesterol levels are dropping. Sounds like you're exercising. I don't know if you weren't exercising before and you're exercising now, or if you were exercising before, now you've increased your exercise, but your feeling is that your exercise is driving those cholesterol numbers down even further. So, do you need to be on statin therapy forever? The question is maybe. I don't know
Mm,
what your cholesterol levels are and where you've managed to get them. But if you've managed to get them down into the normal range without any therapy, then certainly you probably don't need anything. And your doctor can take a look at that.
thank you. This question I'm bringing up specifically because she's mentioning beta blockers. She had a full cardiac workup for palpitations. Everything came up clean. Unfortunately, I was given a beta blocker. What would that
Mhm.
be about?
Yeah, very common. And again, I don't know, you said everything is clean, but I don't know if you have mitral valve prolapse, which could be very common. I also don't know, again, how old this person is, how long they've been
Okay.
on beta blockers. So
Mm-hmm.
here's what I will say without having all of the information. What I will say is beta blockers are a common treatment for symptomatic palpitations. They worked you up and didn't find anything. I don't exactly know what that means. Maybe they found something they didn't think it was life-threatening. I'm not really sure. But depending on your age and where you are, it may be worthwhile for you to see a menopause hormone therapy specialist and have an opinion from that lens on what should be done about your palpitations now that you are satisfied that your cardiac workup was negative.
Thank you. Um, I have high cholesterol and symptoms of atherosclerosis. Did I pronounce that correctly?
Uh,
My doctor put me on statins, progesterone, vaginal estrogen, and metformin all at the same time. I felt more energy right away and then felt like I got the stomach flu. I was taking baby aspirin, but my doctor said to stop. I
mhm.
now take the statin, progesterone, and estrogen and only take the metformin occasionally. Do you think I should stop and take only one of these at a time to see what the effects are? Thank you.
That is a complicated question. I'm going to refer you back to your doctor. I never recommend that you stop medication that a doctor prescribed. I heard you say progesterone, but not estrogen. Again, I don't know how old you are. So these are all questions that you need to take back to your physician. I never recommend that patients take it upon themselves to start stopping their medications.
Mm,
Have this conversation with your doctor. Make certain that they understand what your concerns are, and then let them recommend how to withdraw these medications one at a time if that's something that is of interest to you.
Thank you, Dr. Morgan. Um, I think that I missed the name of the clinical research article. I don't know if you mentioned an article specifically,
Mhm.
but when bringing these concerns to your PCP, do you suggest the article as a reference? I had preeclampsia and I have also had a ruptured brain aneurysm.
Mm. I think it is, so do you need to bring the articles? I don't know exactly what it is that you are bringing up. So let's just talk about preeclampsia. It sounds as if you want to make certain that you are referred to a cardiologist because you had preeclampsia and you did not get that referral. And you've also had a complication, had another medical issue with a brain aneurysm. It doesn't necessarily, you can certainly look these up. You don't necessarily need articles, but you can have these conversations. Most doctors are very receptive and want you to have your best health outcomes. This is not information that's hard to find. So have that conversation with your doctor. If you've had preeclampsia during your pregnancy or someone in your family, you've never been referred to a cardiologist, you want to have that referral. I think that's a conversation that you can have. That will be well received.
Great, thank you. Does menopause uh, make your blood pressure increase?
So the answer to that is yes and no. So
Mm,
during menopause, your blood pressure will begin to increase for a number of reasons. You also are suffering if you have symptoms with insomnia. Decreased sleep also increases your blood pressure. So if you can control your sleep, your blood pressure may decrease somewhat. It's also related to estrogen. So that's a yes and a no question. If you're going into menopause, you already had high blood pressure, menopause is not going to make it better.
okay.
If you haven't had high blood pressure, menopause, you may find that your blood pressure starts to increase during menopause, especially if you're very symptomatic. Again, it's important to address and control all of these symptoms.
Thank you. Just a couple more, Dr. Morgan, and then we'll sadly let you go. Um, I'm sorry, with regards to high cholesterol, is this LDL and total or total only that you're referring to?
So when we talk about cholesterol, we're talking about the whole package, and this can be somewhat complicated. So we're talking about
Mm-hmm.
LDL, talking about
Mm-hmm.
total cholesterol. There's also something called LP little a, which is out on the horizon, that is also more common in people of color, that indicates your risk of heart disease. So your cholesterol levels for for the, I guess, for the purposes of this, it would be your total cholesterol and LDL levels. If those are rising, we want to see them come back down.
Thank you. 63-year-old Black woman, high blood pressure on amlodipine, Norvus, is that correct? Okay. CMP, complete metabolic profile normal, can't get any energy or good sleep. Gynecologist didn't want to give me anything. Oh, sorry, the question just jumped away
She's
from me.
63 or 64. What did she say?
63, excuse me,
Right.
63. Gynecologist didn't want to give me anything but estrogen cream. What should I do? I walk and dance for exercise. Should I see another gynecologist or what?
So I don't exactly know what her question is, but it sounds like she wants to know, is she a candidate for menopausal hormone therapy? And so I don't know when your last period was or how long it has been. So what I will say is there's this theory of the critical window. There's a critical window of time during which systemic estrogen can be prescribed, where women actually receive a benefit. And outside of that window, there may be harm. Now, that that line of thinking is beginning to be blurred. And so once again, I want to make certain that you guys speak with someone, a menopause specialist, has the latest information, has all of the data on you. You guys are, when you're giving me information, I don't have your complete medical record. You want to
Sure.
with your complete medical record and make certain that someone talks with you with that lens as well on menopause hormone therapy.
Thank you. I so appreciate that. And I just have to share this comment that someone made it, and as sorry as I am to hear this, I'm glad for it, and I'm sort of encouraged by it. She wrote, "Thank you. Never heard menopause connection to heart disease. She's 69 with heart failure. Her cardiologist has dismissed her questions. She ends with, please read and educate." And so I just really want to highlight that, as painful as it is to read. And thank you again, Dr. Morgan, for spending this time with us and doing that. I'm going to ask this last question. I'm 52 and I began having heart palpitations and panic attacks. I saw a cardiologist. They did an EKG and it was fine. I wore a cardiac monitor and the results were fine. I'm having extreme insomnia. Could this be a result of perimenopause?
It could be. I guess that means that she's still having menstrual cycles. So it certainly could be. And again, I know I sound like a broken record. You've had this cardiac workup. It was negative. Now it's time to look in another direction and see if there are other options available to you, especially since you are very symptomatic. Sounds like you have insomnia and hot flashes. Talk with someone who's menopause certified. Now that your cardiac workup is negative, it's time to now see if you can seek relief from these symptoms, because these symptoms as well are risk factors for heart disease.
As I said, I feel sorry to let you go, and we must. I thank you first for giving us this extra time. I want to thank everybody who jumped into the Q&A and left such fantastic questions. I always seem to run out of time, and I will work on that. Someone commented, "Thank you so much. This has just been so helpful and insightful." Dr. Morgan, in the last couple of minutes, for anyone who wants to see you more, who's not in Atlanta and won't have the pleasure of seeing you on television, where can people find you?
If you're on social media, I'm at Dr. Jayne Morgan, Jayne. My first name is spelled with a Y, JayneMorgan. Instagram, as well as X and TikTok, and on LinkedIn, I am Jayne Morgan, MD. And I do something from time to time called the Stairwell Chronicles, where I sit on my steps and I answer a question in 60 seconds or less about any number of topics. This week, I am rerunning actually a series of Stairwell Chronicles. Each day I'll be posting one, and it's related to menopause and heart disease, all single week, all week, all through the weekend. I don't know how many I'm running, 7 or 8 or 9. I've posted
Fantastic.
about 2 already. So follow along because these may be questions that you have as well.
Thank you so much. Also, I just want to invite you all to enjoy $20 off any purchase today on myalloy.com using the code CARE20. And I do encourage everyone, as Dr. Morgan did repeatedly throughout this time, to speak to a menopause specialist. It's critical, and they exist on myalloy.com to sort of help you put the pieces of your very vast puzzle together. Dr. Morgan, excuse me, you touched on all of it today, and I feel personally enriched. I know the community does. You're just an enormous gift to all of us, and thank you so much for your wisdom and all of that you shared, for encouraging all of us to really kind of take our health in hand in a way that we may not have been aware of before. Thank you. I look forward to speaking with you again and hearing about how much of the nutritional piece you're ready to speak
Yes,
about.
follow me on my journey. You know, life is all about learning, right? Lifelong learning. So I appreciate it.
Mhm.
Thank you for inviting me. I always enjoy coming.
Oh, a pleasure, a pleasure. Thank you so much, and be well, everyone. See you all soon. Bye.
Bye.
Thank you.